Good evening, everybody. I would like to give you a small lecture about myography in myopathy and neuropathy. We're going to talk about the recruitment pattern and the semi-quantitative analysis in clinical practice. I am teaching, I'm responsible for EMG education in University of Ghent in Belgium, and I'm working as an all-round neurologist in the Netherlands. So for electrodiagnostic evaluation of the muscle, we use in our daily practice a concentric needle. The shaft of the needle, as you can see here, the shaft of the needle functions as a reference electrode. With this reference electrode and with this EMG electrode, we measure the closest 10 to 15 muscle fibers monitored on the screen. Remember that an anatomical motor unit contains at least 100 to thousands of muscle fibers. So we are never recording the whole motor unit. We are just recording a small part of the motor unit, which we call electrophysiological motor unit, and not just the whole anatomical motor unit. During a myography, we evaluate 3 stages, which are the activity at rest. Second, the activity during a weak effort or interference pattern. And third is the activity during maximal voluntary effort, during maximal voluntary exercise. The stability and the excitability of the muscle or the axonal cell membrane might be erroneous in myopathy and polyneuropathy. The structure and the function of the motor units have distinct features in myopathy and polyneuropathy. However, the same discharges of hyperexcitability might occur in both conditions. So of important value in the discrimination between a myopathy and a neuropathic condition is the recruitment pattern. First of all, when we insert a needle in a muscle, we hear some insertional activity. This insertional activity is seen as soon as the electromyographer inserts the needle in the muscle. It appears always in normal muscle, as its source of this insertional activity is the activation of muscle fiber by deformation or the lesion. This insertional activity is absent due to muscle necrosis, like it appears in, for example, hyperkalemic periodic paralysis. This insertional activity is much longer in normal conditions in muscled young individuals or has short runs in positive waves. But it is increased in pathology as a first sign of denervation before spontaneous muscle fiber activity like positive sharp waves and fibrillations appear. So if increased, look at least for denervation potentials. During this evaluation of rest activity, miniature end plate potentials might occur in healthy and sick muscles. The miniature end plate potentials are not a clinical sign of any diagnosis of a severe polyneuropathy or myopathy. They are monophasic negative waves with an amplitude less than 10 microvolts and a short duration of only a few milliseconds. Their significance is an irritation of a terminal nerve fiber, resulting in irregular, fast firing of the single fiber motor action potential. However, if we have fibrillation potentials, well, these are a clear sign of disease. The fibrillation potentials, they are regularly firing, sometimes irregular, with a frequency of 0.5 to 15 hertz. The duration has 1 to 5 milliseconds. The amplitude is about 20 to 200 microvolts. They have a negative deflection in the start. If appearing as positive sharp waves, if the muscle fiber is really disrupted, they are appearing as positive sharp waves. They are a bit longer duration, like to 30 milliseconds, and they are biphasic. But in fact, the fibrillation potential and the positive sharp waves is just the same, has just the same clinical significance. Those fibrillation potentials, they appear after 1 to 2 weeks in proximal muscles, only after 3 to 4 weeks and distal muscles. From the muscle fibers that have been separated from the end plate zone, those fibrillation potentials, they appear. They are like denervated muscle fibers. So they suggest also pathologic features of the muscle fiber necrosis, of splitting, of fiber separation by vacuole formation. They are not specific for neuropathy or myopathy, but correlations are, of course, very strong. But what I want to conclude is that those fibrillation potentials, they appear in both neuropathic and myopathic conditions, and their origin is the muscle itself. So they can appear in inflammatory and infiltrative myopathies. They can appear in muscular dystrophy, in toxic myopathy, and in some endocrine, metabolic, or congenital myopathic conditions. If there is absence of fibrillation potentials, of course, other types of myopathy might be in our list of differential diagnosis. So it's not that fibrillation potentials should be seen in any case of myopathic condition. On top of this screen, we see a sharp wave in a sweep of 100 milliseconds and the sensitivity of 50 microvolt per division. I mean that here, one division is 50 microvolts, and a sweep is from here till the end of the screen. The sweep is 100 milliseconds. So this discharge has an amplitude of 1, 2, 3, 4 divisions of 50 microvolts, so it's 200 microvolts, and a duration of about less than 10 milliseconds, about 5 milliseconds. This is a positive sharp wave. In the bottom, we see a different form with a clear negative deflection. This is a fibrillation potential. Look in this sample at the regular firing of this positive sharp wave with a frequency just above 10 Hertz, which means 10 Hertz is one positive sharp wave in a sweep of 100 milliseconds on the screen. So 10 Hertz is in every screen, one positive sharp wave. Try to look at the regular firing. Okay. So we discussed the miniature end plate potentials and then the disease-specific fibrillations and positive sharp waves. Next on the list is a myotonic discharge. In a myotonic discharge, the single fiber motor action potentials appear, but they are appearing longer lasting, faster, and they are appearing after excitation of the muscle. They are rhythmic and very regular. They have a frequency, those single fiber muscle action potentials, of 40 to 100 Hertz. Their amplitude is a few 100 microvolts. They look like fibrillation potentials or positive sharp waves. It is in fact a spontaneous firing of single muscle fibers. Myotonic discharges have very high specificity for inflammation, for necrosis, for splitting, or vacuolar changes. That's why we see myotonic discharges in diseases like myotonic dystrophy type 1, myotonic dystrophy type 2, also myotonia congenita, paramyotonia congenita. If you consider the literature, there are small differences in how the myotonic discharges appear in DM1 versus DM2. In this screen, I will show you in a sweep of 1 second and a sensitivity of 200 microvolt, I will show you some myotonic discharges. Try to look and try to listen to the sound of the myotonic discharges. The sweep duration is 1 second. The sensitivity is 200 microvolt. If we count how many divisions the myotonic discharges have, it's 4 to 5, which means that they go up to 1 millivolt. The amplitude of the fibrillation-like discharges is between 400 microvolt and 1 millivolt. The frequency is between 60 and 80 Hertz. Next are the complex repetitive discharges. Complex repetitive discharges, they appear as spontaneous motor action potentials of single muscle fibers, but not necessarily of the same motor unit, but physically closely related muscle fibers. There is from one muscle fiber what we call an hepatic transmission to another muscle fiber. Hepatic transmission means the direct transmission of the wave of depolarization from one cell to another. And this is how appear this screen of one muscle fiber firing at a very regular rate, and then suddenly another muscle fiber appears in the same complex repetitive discharge. This is because of the hepatic transmission. So the frequency of a complex repetitive discharge goes to several tens of hertz. As long as we have the same number of muscle fibers, we have a constant noise. But as we have this hepatic transmission and we go from one muscle fiber to another muscle fiber, the frequency can suddenly change. An abrupt beginning and abrupt ending is very specific for this complex repetitive discharge. These complex repetitive discharges of CRDs appear in motor neuron disease, in axonal neuropathy, radiculopathy, in myositis, dystrophy, and other myopathic conditions. This is a sample where the sweep duration is 100 milliseconds and the sensitivity is about 50 microvolts. We see two different single muscle fibers with a different frequency. Let's look at the first one. 1, 2, 3, 4, 5, 6, 7 in 100 milliseconds, which means a frequency of 70 hertz. Look at the second one. 1, 2, 3 inside, 4, 5, 6, 7, 8, 9. This muscle fiber is firing at a frequency of 90 hertz. In between the insertional activities that you're going to see in this sample, we will see various complex repetitive discharges. Try to look. This is CRD. Again, CRD. Again, complex repetitive discharge. Again, complex repetitive discharge. Those complex repetitive discharges, like we see here on the screen, we have one muscle fiber, 1, 2, 3, 4, 5 times the same one. And here there is another muscle fiber, 1, 2, 3, 4, 5, 6, 7, 8, 9 in 100 milliseconds, 90 hertz. Those complex repetitive discharges, they appear very suddenly, and they just appear, begin and start very suddenly. So they're quite short, they're short lasting, not as in myotonic discharges. Next are the myochemias. The myochemias, they are spontaneous discharges, not of the muscle fibers like in complex repetitive discharges, but discharges of axons, which initiates a volley of activity, causing afferent fibers to stimulate afferent fibers. So we have a stimulation from the axons, which is the cause of a myochemia. So in a myochemia, we have different motor units because the axon is firing to all its muscle fibers. We have the different motor units which are firing in one burst of a myochemia. So in a myochemia, we find 2 to 10 motor unit action potentials with a frequency of 50 to 150 hertz inside a burst, and then there is an intra-burst frequency of 10 hertz, of 2 to 10 hertz. Within a burst, the motor units, they always have a normal wave and the same wave. Those myochemias are due to biochemical alterations in the axon microenvironment. Those myochemias, they can appear, for example, after radiation. And a few days ago, I had a patient with a cancer of the parotid gland 10 years ago. she got some radiotherapy, and now after so many years, she has some kind of atrophy of speech muscles and of her tongue. When we put when we did the needle myography of the tongue, we saw this kind of myochemias. They can appear as well in brainstem disease, sometimes in a motoneuropathy, and sometimes in motor neuron disorder. Also, generalized conditions can give reason to find these myochemias. Look and listen to this example. You will never forget if you hear it once. So this example shows in the cascades over here on the right, a motor unit firing at a frequency somewhat slower than 20 Hertz. The myochemia consists of about 20 small motor unit action potentials. Here we see the myochemia in its different bursts. On top, this is one burst, this is one burst, this is one burst, this is one burst. And within the burst, here we see the cascades of the motor units in the burst itself. Look once more. So what we see is what is inside one burst of a myochemia. So focal pathologies as radiation, brainstem problems, mononeuropathy can give rise to this kind of myochemia. Generalized myopathic and neuropathic pathologies can show these as well. Here again, we try to differentiate myotonic discharges from myochemic and neuromyotonic discharges. Myotonic discharges, they appear from the muscle fiber itself, while myochemic discharges appear from the axon. In myotonic discharge, we have a continuous firing of the discharges of the muscle fiber. In myochemic discharges, we have the typical bursts. Within the burst, there is a frequency of less than 150 Hertz. In a myotonic discharge, a frequency of less than 40 Hertz. But in the myochemic discharges, we also have this frequency of the bursts itself, which goes up to 10 Hertz. Try to differentiate very well myochemic discharges from just a tremor registration, like we have also in frequencies between 5 and 10 Hertz. Okay, next are the fasciculations. A fasciculation is an irregular and spontaneous motor unit action potential with variable form and amplitude. It is the whole motor unit which is firing in a fasciculation. It is generated along the motor unit axon. Of course, we have a lot of benign fasciculations. Post-exercise, there is an increase in fasciculations and the gastrocnemius in the first 10 hours after the exercise. But patients, they are very afraid of having a severe disease because they Google on the internet and they read fasciculations is prone to be motor neuron disorder. So that's the reason why they come to the neurologist. And that's the reason why the neurologist can verify if there is some underlying disease and verify with EMG if it's only about fasciculations or is it fasciculations apart from active denervation in the muscle. So we make a difference between benign fasciculations with a higher frequency and they are more stable, or a neurogenic disease. And then we are looking for fasciculations in the abductor hallucis more than the tibialis anterior, more than in the quadriceps. The Hawaii criteria in 2006, they defined large complex fasciculations as a evidence of ongoing denervation in motor neuron disease. In this sample, we see a fasciculation. This fasciculation is shown on a sweep of 100 milliseconds. We see about 1 to 2 divisions of 100 milliseconds, so duration goes up to 15, 20 milliseconds. Has a high amplitude of 10 divisions of 500 microvolts, so it goes up to 5 millivolt as amplitude of a fasciculation. Again, after the activity at rest, we go with our needle to look at some activity during week effort. So we're going to find some more evidence for the recruitment pattern of the muscle fiber of the motor unit. In a denervated muscle, the death of an axon puts a stress on the other innervated muscle fibers. So here we have denervation. The death of this axon puts a stress on this axon to fire harder, to fire more frequently towards those muscle fibers. When asking for a stronger contraction, the surviving motor unit has to fire more frequently before other healthy motor units are recruited. So the firing frequency in this denervated muscle gets higher. So there is a lower recruitment of other motor units, and there is a higher frequency of the same motor unit firing. So in a neurogenic condition, or in this condition, we can find a reduced recruitment with a higher frequency of the same motor unit firing. Otherwise, in a myopathic condition, all the axons are still alive, but the muscle fibers in the motor unit, they get atrophic, they get smaller. When asking for more contraction to the patient, one motor unit with necrotic or atrophic muscle fibers cannot perform that well. So there will be very soon a recruitment of other motor units. So the recruitment pattern will be different than in a neurogenic condition. The recruitment pattern will be induced, will be higher, will be faster than in a neurogenic condition. So we have a higher recruitment pattern with a lower frequency of one motor unit before another motor unit is recruited. So due to reinnervation, neuropathic motor units become bigger and wider, but especially in inflammatory myopathies like inclusion body myositis, those reinnervated neurogenic motor units are also common features. So the amplitude and the duration of a motor unit is not a clear sign whether the condition is neurogenic or myopathic. However, the recruitment pattern based on this principle remains very different in neuropathic and myopathic conditions. In this sample, in this snapshot of the quadriceps, we see three different motor units. 1, 2, 3. Those three different motor units, they are firing again and again and again in a sweep of 1 second with a sensitivity of 1 millivolt per division. The fastest firing motor unit in this sample is the smallest one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 hertz. As there are three motor units, the firing ratio is 12 or 11 divided by 3, which is 4. So the firing ratio is 4 in this sample. The normal firing ratio is 5. So when a normal motor unit fires at 5 hertz, a second one should be addressed. So in this case, when we have a frequency of the fastest one of 11 or 12 hertz, we are expecting for each 5 hertz a new motor unit. So we are expecting 3 motor units with a frequency of the fastest one of 12 hertz. So this is a normal recruitment pattern, a snapshot of a normal recruitment pattern in the quadriceps muscle. Muscles in the hand responsible for very precise movements have less muscle fibers than big muscles of, for example, the tibialis anterior. We might postulate that the electrical motor unit is a reflection of the number of muscle fibers. However, the anatomical motor unit consists of many more muscle fibers per motor unit. When small gradations of muscle strength are important, for example, in the movement of our small hand muscles, we need motor units with less muscle fibers. So this is the reason why we see that, for example, in the hypotenar muscles, we have number of muscle fibers very high, but the number of muscle fibers per monad unit is much lower than, for example, in the bigger muscles like the tibialis anterior. So the lower the motor units in one muscle, the higher the precision of the activity we can perform. This is a sample of a contraction of the peroneus tertius muscle, where we see a normal recruitment of a first, of a second, and finally a third motor unit. So here on the snapshot of the start, we see one motor unit firing 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 times in a sweep of 1 second. Look how the recruitment will evolve during this small, weak contraction of the muscle. The second motor unit is firing. We can hear the difference. We hear a regular pattern of 2 motor units. You see a difference in amplitude and hear different sound. And now a third motor unit is firing. When I stop the screen, here we see 1, 2, 3 motor units firing with a normal frequency in a sweep of 1 second. This is a normal recruitment pattern in the muscle, the peroneus tertius of this patient. In this sample, we see the recruitment pattern of a tibialis anterior recruitment starting with 2 separate motor units. The frequency of the individual motor units, of course, they can change a few hertz during the recording, but we will hear and we will see a very normal, clear recruitment of 2 motor units. So this is the first one. This is the second one. The first one is firing 1, 2, 3, 4, 5, 6, 7, 8, 9 hertz. The second one also as well, about 9 to 10 hertz. We listen to the sound. A very rhythmic, regular pattern of firing of the 2 motor units. Okay. In a patient with a femoralis neuropathy, we examine the activity during a weak effort of the quadriceps muscle. In this sample, a sweep of 1 second, the sensitivity of 1 millivolt, we will see that the same motor unit will fire at a very high frequency, at a higher frequency than normal. Even important during this qualitative myography is the sound of the sputtering motor unit when the same motor unit fires at higher rates. So we're going to watch at the higher frequency, but we're going to listen as well to the higher sputtering motor of this motor unit. As well, in this snapshot at the start, we see this motor unit firing 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 times. So remember, in our first sample, for 14 hertz, we had already a second and a third motor unit firing. Here, of course, there are the small activities over here, but we don't see a clear, sharp motor unit firing in the neighborhood of this first one. We listen to the sound of this reduced recruitment with higher frequency of this motor unit. Listen to the higher frequency, the sputtering motor. We consider this as a poor contraction pattern. there is a reduced recruitment because we were expecting already more motor units to recruit, and there is a higher frequency of the same motor units. So the evolution of the electromyography findings in acute and a chronic neurogenic disorder is very typical. In the first week after a condition has been posed to be a neurogenic disorder, in the first week we have only reduced recruitment. Just after 2 weeks, we have not only reduced recruitment, but also some fibrillation, some active denervation. After 6 weeks, we have still a reduced recruitment, which remains even after 6 months, but we have more active denervation potentials like fibrillations. So I want to stress, based on this article published in 2008 from during the courses of the American Academy of Neurophysiology and Electrodiagnostic Medicine, I want to stress that from the beginning, the recruitment is reduced, while those active denervation potentials, they will only appear after a few weeks in our EMG examination. So when we consider the interference pattern of a myopathy in a myopathic condition, we have a shorter duration, a lower amplitude, and a polyphasic pattern due to the atrophy of the motor unit, due to the atrophy of the muscle fibers. Due to the atrophy, of course, the duration is smaller. Due to the atrophy, the amplitude of all the motor units, of all the muscle fibers firing together in the motor unit becomes lower. And of course, there's more polyphasic because all those muscle fibers in the same motor unit, they will not discharge at the same time. So there is a loss of muscle fibers, there is a fiber size variation, and there is a regeneration or re-innervation of the fibers. And this is the reason why we have this typical interference pattern of myopathy. This pattern is not specific for types of myopathy. The fibrillation potentials are less sensitive, but more specific for inflammation and necrosis. So I repeat that the rapid recruitment is typical for inflammation with increased connective tissue with regenerating fibers. The short duration of the interference pattern of myopathy appears due to inflammation, due to increased connective tissue, due to necrotic, atrophic, regenerating fibers. Later on, we have the longer duration, like for example, as I showed you before in occlusion body myositis, the longer duration due to fiber type grouping. We have increased complexity with increased connective tissue, necrotic, atrophic, and regenerating fibers. So this is very typical for interference pattern of myopathy. In this sample, we see a couple of small polyphasic motor units. So we could consider, okay, is this a myopathic condition, yes or no? But we see that the sweep of this snapshot is 1 second. So one division is 10 milliseconds. The duration of a polyphasic motor unit is for sure not in the classical myopathic range. The duration over here is about 4-5 milliseconds. In this extensor hallucis longus muscle, the clue to conclude poor recruitment and neurogenic condition is more in the sound than in the visual evaluation, because difficult to see the difference between the different motor units. But listen to the sound, listen to the sputtering motor unit in this sample. By turning the needle a little during the myography, the amplitude difference between the motor units becomes more clear. Let's listen. This is the sputtering. This is sputtering, neurogenic condition. So in the same muscle, we have these small polyphasic potentials, but also later on the reduced recruitment. There is clear evidence for a neurogenic condition with some probable myopathic motor units in the same muscle. So during all these qualitative evaluations of the neurophysiologist, the patient has to be, the neurophysiologist has to be very patient and filter single motor units, which is not easy because we have to ask the patient just to contract a very small contraction of one muscle, which is very difficult. So in semi-quantitative multi-map analysis, the software of the program, the software algorithm, they filter individual motor units out of a richer contraction pattern. And this is an example where we ask the patient to contract the right deltoid muscle, and the algorithm of the program software filters itself the different motor units. In a semi-quantitative multi-motor unit analysis, the software filters individual motor units out of a richer contraction pattern. At the end, the mean of the metric values of amplitude, duration, and polyphasic patterns are automatically calculated. Here, for example, this is a sample of a deltoid muscle. On the left, 2 months after luxation, on the right, 7 months after luxation. We see on the left a lot of polyphasic potentials. On the right, we see quite bigger potentials. The amplitude is a bit higher. We can evaluate this like we always did during the past 10s, 20s years. We can evaluate this very objectively, but we can also do quite objective evaluation. And then the computer measures the metric values of the nascent units with a duration of 10.3 milliseconds, only a few months after luxation, and later on the duration gets much bigger, much longer, to 14.7 milliseconds. The same appears at the difference of the amplitude. The rate innervation potentials, they get higher, they have a higher amplitude than just 2 months after luxation. So this is a semi-quantitative analysis, which is already better than our traditional qualitative analysis. So when we consider our myography of the muscles, when we consider it in a very subjective manner, qualitative analysis, the 95% confidence limits in EMG are as follows. Spontaneous activity should be present in 2 sites of 10 investigated sites of the muscle. Weak voluntary effort with a mean of 25 motor units evaluated should show a motor unit potential duration that is 20% outside the normal range of the duration of that specific muscle. The motor unit potential amplitude should be between 50% less or 100% more than the normal range, which is about 2 millivolts. The incidence of polyphasic potentials should be at least 12% of all the motor units that we evaluated in one muscle. So we are not happy when we see just one positive sharp wave. We are not happy when we see just one motor unit with a polyphasic appearance. We need to consider more motor units, not only in the rest activity, but also in the contraction activity. During maximal voluntary contraction, we want to see a full recruitment with the amplitude of 2 to 4 millivolt. Here we see an example of contraction of a muscle where we see on the left 1 motor unit. On the right, it cascades where we appear to see the frequency of this 1 motor unit in 1 second. And over here, there is a long trace. This is a tibialis anterior muscle of a patient suspected to have Charcot-Marie-Tooth, to have a sensory motor congenital neuropathy. As we can see, this 1 motor unit is very polyphasic, has a long duration of more than 2 divisions, so it goes to 20 milliseconds. When we go to see the frequency of the recruitment, in this 1 second, because it's 10 cascades, of each cascade 100 milliseconds, we see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, at least 12 different discharges in 1 second without any other motor unit firing. So there is an increased frequency or reduced recruitment with a higher duration and a higher amplitude of a single motor unit. So this is a typical neurogenic condition. Let's look at our recording. We see the very wide and high amplitude motor units. On the right in the cascades, we see the frequency, which goes up to 10 per second. Now I am triggering with a cross. I was triggering one motor unit to evaluate a single motor unit. And now again on the right, we see the high frequency. The high frequency, you can see it because the line of the motor unit goes like this from right up to down left. So there is more than one motor unit in 100 milliseconds firing. This is still semi-qualitative analysis. Now we're going to go to semi-quantitative analysis. What we measure here is on top the normal contraction pattern. I'm looking for a sharp motor unit, which means that on the EMG quality monitor, I want to see green with a sharp rising time. If I have a sharp motor unit, I try to record this motor unit over here. This recording of the motor unit gets analyzed by the computer software over here. So here we have the analysis of 1, 2, 3, 4 different motor units with how many turns per second the computer measures in one motor unit, the amplitude, and then the turns over amplitude. This is plot over here, and it's normal when it is within this cloud. So for this muscle, we have about 6 motor units analyzed. They are plotted in this box, amplitude versus turns. And over here, all those dots are within the cloud, so they have a normal amplitude, normal turns per second. So this muscle is no neurogenic, has no myopathic condition. In a neurogenic condition, we should expect that the amplitude gets higher for the same turns per second. So in neurogenic condition, the blots or the blots would be over here. In a myopathic condition, the amplitude is of course very low, and there is a lot of polyphasic answering in the motor unit. So over here, the plots would be in a myopathic condition. Let's look at the next example. The tibialis anterior. Again, we measure on top the motor units. If we have a sharp motor unit seen on the screen here, we select re-record. We go to analyze, or we ask for analysis by the computer. Turns and amplitude is plotted over here in this box. We see that the plots are measured or plotted over here with a high amplitude and normal turns per second. When at the end we will put the cloud of the specific muscle over here on this box, you will see that those measurements are out of the box, very specific for a neurogenic condition. The cloud specific for age, specific for gender. Okay, we see all the dots outside the cloud, which is typical for a neurogenic condition. So this is a semi-quantitative analysis of a normal contraction pattern giving rise to neurogenic condition. So to conclude my lecture, I want to stress that denervation discharges are common in neuropathy and myopathy, but that in myopathy, the recruitment is increased, and polyneuropathy, the recruitment is poor. To have a clear overview whether the motor units that we measure are myopathic or neuropathic, we should combine our former qualitative analysis with semi-quantitative analysis, which helps to segregate and evaluate the individual motor units. I would like to thank you for your attention, and if there are any questions, please ask. Thank you very much for the invitation.